Good afternoon, everyone. Welcome to the Yale Sleep Seminar Series. My name is Ritika Thapa. I'm one of the faculties here at Yale. I'd just like to make some brief housekeeping announcements before we introduce our today's speaker. Please take a moment to ensure that you're muted. And in order to receive the CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room or unmute yourself at the end of the talk, and you can ask the questions on your own. Okay, and without any further delay, we have Dr. Yvonne Chu, who will introduce our today's speaker, one of our excellent fellows, Dr. Vesna Buntak.
Hi, good afternoon, everyone. So I'm Yvonne Chu, standing in for Andre Zinchuk, who's actually attending in the ICU and unable to join us. Today, I have the honor of introducing our very own Yale Sleep Fellow, Dr. Vesna Buntak, who will be talking to us about hypoglossal nerve stimulation for the treatment of OSA. Dr. Buntak completed medical school in Croatia before coming to the US, where she did her internal medicine residency through the Canton Medical Education Foundation in Ohio, where she also served as chief resident and received numerous awards in teaching, professionalism, and leadership. She then went on to complete pulmonary critical care training at Yale New Haven Health Bridgeport Hospital. While at Bridgeport, she cultivated her love for sleep medicine. She was awarded a research grant to conduct an ongoing pilot study on the impact of sinus irrigation on nasal symptoms in CPAP users. It has been an absolute pleasure to work with Dr. Buntak in our sleep clinic this year. She's enthusiastic, personable, and a joy to work with. And above all, she is known to go above and beyond to ensure the best care for all of her patients. Additionally, Dr. Buntak has worked closely with Dr. Zinchuk in the management of Inspire patients. She has completed training through the Inspire Institute of Excellence in Upper Airway Stimulation. And after sleep fellowship, she will be joining the Pulmonary Critical Care Sleep faculty at Brown University, where she has plans to establish an upper airway stimulation program. And without delay, I'm going to now hand it over to Dr. Buntak.
Thank you so much. So I'm very happy to be here today, and I hope to take you on this exciting journey where technology meets pathophysiology. As you already heard, my mentor is saving lives on ICU nights, so he will not be with us. My sleep medicine journey would not be as half fun without his incredible kindness, patience, expertise, and dad jokes. I'm very happy that the moderator today is Dr. Chu, who is actually spearing Inspire at our VA clinic. I did receive material from Inspire for this lecture, so there will be some figures from them. I again appreciate Dr. Zinchuk's help as well as of the entire Yale Inspire team. I will use the terms upper airway stimulation, hypoglossal nerve stimulator, and Inspire interchangeably. We do have a lot to cover, so let's start. The American Heart Association has added sleep to their cardiovascular health checklist in 2022, emphasizing the importance of sleep. 80% of OSA worldwide may be underdiagnosed. It is believed that 30 million US adults have OSA, with estimated 22 million Americans suffering from moderate to severe OSA. Untreated obstructive sleep apnea is associated with significant comorbidities and mortality. Dr. Sullivan invented a device called continuous positive airway pressure in the 80s at the University of Sydney. It was initially tested on dogs, but it turned out to work in humans too, as evidenced by this enthusiastic research participants. The original CPAP was a pretty sweet device. Not only it could be used for sleep, but as a killer snorkel. And it turned out to be a more tolerable choice than tracheostomy. I do want to quickly talk about the concept of effective AHI. In this study, patients with severe OSA were recruited to undergo an in-lab research PSG, where they used PAP for the portion of the night that they would normally use it at home. The researchers found that 6 hours or more of nightly PAP use is needed to normalize the effective AHI. The question of clinical importance of residual AHI burden remains unclear, but there are studies showing that REM-predominant OSA carries higher risk for recurrent cardiovascular events. Therefore, not using PAP in the latter part of the night might carry severe consequences. This is quite different from the Medicare rule asking for more than 4 hours per night and not every night. Although PAP is highly effective, up to 1/2 of patients with OSA have substantial difficulty tolerating it. We do have other modalities at our disposal, such as mandibular advancement device, positional therapy, different types of surgeries, hypoglossal nerve stimulator. There are drugs and targets for neurostimulation in the pipeline, with tirzepatide being hot off the press as a treatment for OSA. However, today we focus on hypoglossal nerve stimulator, often requested by our patients struggling with PAP. In 1993, a study with 11 patients demonstrated that hypoglossal nerve stimulator was capable of keeping the airway open during sleep in OSA patients, but could not break an apnea once it was established. First implant was done in Belgium in 1997, with first paper published by Dr. Schwartz in 2001, representing 8 patients from multiple centers in Europe and from Johns Hopkins. This study proposed that unilateral electrical stimulation of the hypoglossal nerve was a feasible and potential therapeutic option for OSA. Efficacy of OSA treatment was shown in 7 out of 8 implanted patients. For the 6-month continuation of the study, the results were consistent. They were not successful in the long term due to technical defects that led to device dysfunction. Inspire, as we know it today, was formed in 2007 when the technology and intellectual property portfolio were spun out of Medtronic. Finding out the right population and fine-tuning the technology took over a decade. In 2014, the pivotal clinical STAR trial was published. 22 medical centers from US and Europe were enrolled. The study included 126 participants with moderate to severe OSA in whom PAP had failed or was not tolerated. 83% were men, the mean age was 54, and the mean BMI was 28. Success was measured by SURE criteria, that is a reduction in AHI more than 50 and final AHI less than 20. The median AHI score at 12 months decreased by 68% from 29 events to 9 events per hour. The ODI score decreased 70% from 25.4 events per hour to 7.4 events per hour. Secondary outcomes showed reduction in the effects of sleep apnea and improved quality of life. Looking at the breakdown, 29% of patients achieved AHI less than 5. 19 participants qualified as non-responders, showed an increase in their AHI. 7 individuals had an increase in their AHI above 15 per hour and 12 below 15 per hour. There were 4 individuals with an increase of AHI above 60 at 12 months. 3 of 4 had a post-implant sleep endoscopy where the retropalatal airway remained closed despite elimination of tongue-based collapse with stimulation. 2 of 3 also exhibited significant central and mixed apnea during their second baseline PSG post-implant and at 12 months. Remaining 1 participant had anatomical issues with maxillomandibular deficiency and low anterior hyoid bone, resulting in a long, narrow upper airway. Less than 2% of patients had a serious adverse event. These events resulted in device repositioning to alleviate patient discomfort. No patient had permanent tongue weakness, and 21% of patients had tongue soreness, which most often resolved with acclimatization of the device over time. Post-market center single-arm study with 60 patients wanted to see how Inspire will work in the real world. I found it interesting that the final data was derived from 2-night home sleep study. Average patient was a 56-year-old male with an AHI of 31, ESS of 12, and FOSQ of 13. To remind ourselves, functional outcomes of sleep questionnaire have been used to measure the impact of daytime sleepiness on activities of daily living. The score ranges from 5 till 20, with higher scores indicating better functional status, and scores less than 18 are considered abnormal. These figures compare data from the German study to the data from the STAR trial. Among the 60 participants, the median AHI reduced from 28.6 at baseline to 9.5 at 12 months. Patient-reported outcome measured in ESS and FOSQ both improved significantly from baseline to 12 months. The average use time was 6 hours per night among all participants. One participant did request removal of the device for cosmetic and other personal reasons and was completed without sequelae. Therapy response via SURE criteria was achieved among 73% of participants at 12 months, which was similar to the 66 reduction in the STAR trial. Comparison of responders and non-responders at 12 months showed no difference in baseline demographics, including age, BMI, neck circumference, AHI, ODI, FOSQ, and ESS. As noted, at 12-month visit, the SURE criteria were met by 66% of participants. 98 participants additionally agreed to a voluntary 36-month PSG. Self-reported daily usage of the device was 81%. In the PSG group, 74% met the a priori definition of success with AHI, reduced from the median value of 28 events per hour to a baseline of 8.7 at 12 months. 6.2 at 36 months, and similarly, self-reported outcomes improved from baseline and were maintained at 36 months. At 5 years, 97 individuals completed the protocol and 71 consented to a voluntary polysomnogram, and AHI response rate remained high. Soft or no snoring reported by bed partner increased from 17% at baseline to 80% at 36 months. So Inspire is helping to prevent sleep divorce as well. The ADHERE registry is a post-market, multi-center observational registry that was designed to collect data related to the use and effectiveness of Inspire. Data from the ADHERE registry has prompted the FDA to expand approval to include patients with higher AHI and patients with higher BMI, a group not initially studied in the STAR trial. Data also suggested that the benefit is long-lasting, provided patients adhere to therapy. This registry reported an average therapy usage of approximately 5.6 hours per night, an AHI reduction from 36 to 14.5 events at 2 years. At 9 years, there was a 50% reduction in the AHI from baseline to the latest follow-up, and the mean therapy use was 7.2 hours per night. Caveat, it was a small number of patients, 14 to be exact. The ADHERE registry reported that 92% of the patients had a better experience with hypoglossal nerve stimulator than with PAP therapy. Let's take a closer look at the data for the expansion of eligibility. The effectiveness results from the ADHERE registry in patients 65 to 100 AHI and BMI of 32 to 40 showed consistent results with those of the STAR trial subjects. Note that 57% were enrolled in the analysis supporting the higher AHI and 279 patients for the higher BMI cutoff. Now let's turn to some data looking at outcomes with hypoglossal nerve stimulator. Authors compared blood pressure, ESS scores, and therapy usage, and similarly matched patients with PAP or upper airway stimulator. Clinic-based blood pressure and ESS scores were compared between 517 patients with moderate to severe OSA initiating PAP therapy at Cleveland Clinic, and 320 patients with upper airway stimulator via ADHERE registry with 2 to 6 months follow-up. PAP show greater improvement in diastolic and mean arterial pressure compared to upper airway stimulator. Upper airway stimulator showed greater improvement in ESS scores, and therapy usage was 6.2 hours per week greater than PAP-treated patients. Results were consistent following adjustments for the therapy adherence. PAP did show greater improvement in blood pressure, potentially reflecting the enhanced ability of PAP to exert beneficial mechanistical intrathoracic, cardiac, and vascular influences. This study represents a systematic literature search of Medline, Cochrane, and Web of Science. 34 publications looking at almost 4,000 patients, mostly observational data on patient-reported outcomes with hypoglossal nerve stimulator. Data on FOSQ to assess changes in daytime functioning were available from 900 patients. Study found 2.84 points improvement in daytime functioning, and more than 2 points difference is considered significant. The analysis revealed a pool effect of 4.9 points improvement in daytime sleepiness as measured by ESS. ISI and PHQ-9 showed no difference, but there was beneficial effect on fatigue. In summary, hypoglossal nerve stimulator was successful in reducing disease burden and symptom relief with more usage time. As of July 2023, FDA has approved Inspire or hypoglossal nerve stimulator for all adults above 22 years of age. I will not go into eligibility for our pediatric criteria. AHI 15 to 100, however, CMS is still limiting it to 65. BMI less than 40 per FDA, CMS is still limiting to 35. And then we have our CPAP failure or CPAP intolerance despite CPAP interface and or setting optimizations, absence of complete airway blockage. And to this day, FDA only approved Inspire in the USA. Exclusion criteria can be broadly divided into more than 25 of AHI central or mixed in origin, then neuromuscular disorders, hypoglossal nerve issues, inability to control remote. CMS adds severe cardiovascular pathology, psychiatric disorders, and non-respiratory sleep disorders. I do want to go back to anatomy just for a bit. Obstruction in OSA may occur at all sites of the upper respiratory tract, and it usually occurs in the soft palate, tongue base, and epiglottis area. The hypoglossal nerve innervates all the extrinsic muscles which affect the tongue appearance and all but one of extrinsic muscles of the tongue. The genioglossus is the largest and major pharyngeal dilator that maintains airway patency during sleep by protruding the tongue and dilating the pharynx. Inspire aim is to relieve tongue-based obstruction during sleep by stimulating the hypoglossal nerve, producing tongue stiffening and protrusion with inspiration, resulting in upper airway patency during sleep. This is the bird view of our Inspire pathway at Yale, so let's go through the steps. During our initial visit, we will go through our eligibility and exclusion criteria, dig deep if they really tried PAP, have other alternatives been explored, obtain a detailed sleep history, and talk about sleep hygiene. Explore for COMISA or comorbid OSA and insomnia, or primary insomnia, which is present in 25 to 80% of patients presenting for evaluation. Inquire about RLS symptoms, as well as other causes of fatigue, such as hypothyroidism. Insomnia presents a challenge with starting and using Inspire and should be thoroughly addressed. Also important is that depression is more prevalent in this population and may influence adherence. This study tried addressing the question by using self-reported questionnaires administered to all patients older than 50 years seeking a hypoglossal nerve stimulator consultation at a large university here in the States. They included 113 adults with severe OSA. 88% of patients reported elevated insomnia symptoms. 30% reported mild difficulty with physical functioning, and 36 indicated that they had experienced moderate to severe daytime impairments attributed to poor sleep. Additionally, they found 28% of sampled individuals reported moderate severe depressive symptomatology. Over 90% reported moderate severe anxiety, and over 17% reported moderate to severe anger issues. Approximately 38% of the sample reported moderate to severe cognitive difficulties. And this sample does correlate to what we see in our clinic as well. It is very important to set goals. Explaining to the patient, hypoglossal nerve stimulator involves surgery. It is a slow process and not a quick fix. Primary outcome, again, is considered as a reduction of AHI by more than 50%, final AHI below 20. Secondary outcomes are improvement in ESS and FOSQ. These outcomes are good for benchmarks used for trial, but one must ask themselves, is our goal ameliorating the sleep disorder breathing or eliminating it? Another important point is clarifying patients' goals and expectations and an honest discussion of what is reasonably achievable. How can we predict challenges in our patients? Authors in this study used raw baseline PSG data from 91 patients. Traits such as loop gain, arousal threshold, collapsibility, and muscle compensation were calculated. A lower arousal threshold was a strong determinant of incomplete hypoglossal nerve efficacy with odds ratio of 6. Although current criteria for hypoglossal nerve stimulator selection focuses on anatomical markers such as AHI, BMI, drug-induced sleep endoscopy, these results indicate the pathophysiological traits play a role not only in OSA endotypes, but also in INSPIRE outcomes, with promising implication for advanced patient selection and moving towards precision medicine. Talking about DICE, this is a procedure performed by our ENTs after they agreed patient is a candidate for hypoglossal nerve stimulator. 15 to 20-minute procedure time, mild sedation with propofol to mimic sleep, and the majority of patients are good candidates. On the left side, we can see anterior-posterior collapse with preservation of lateral wall distance, while on the right, the airway appears almost as a sphincter closing off, demonstrating complete concentric collapse, thus ruling out this individual for INSPIRE. Complete concentric collapse is defined as lateral wall collapse greater than 75%. And again, those are the people we are ruling out for INSPIRE. We are not necessarily looking for patients to have AP collapse. We're looking for those patients who have severe concentric collapse or this added lateral component of their collapse greater than 75%. It appears that there is a candidacy continuum. With the data from the ADHERE registry, Heiser showed that for each 1 unit increase of BMI, there is 9% reduced odds of treatment success. BMI was also a predictor for lower hypoglossal nerve stimulator adherence. On the other hand, while Stefan found that higher BMIs and AHI values were predictive of complete concentric collapse, more than 50% of patients in this study with a BMI larger than 32 did not have complete collapse. In the initial ADHERE registry, there was some suggestions that females had better results compared to males, but this was not a significant difference. And we are all aware that women are underrepresented in OSA trials. The subsequent update of ADHERE registry study, which included more than 1,000 patients, 26% being females, still showed that female sex appeared as a predictor of therapy response. A study by Laundrie identified a positive predictive relationship between peak RIT and therapeutic PAP level, permitting the use of PAP levels as a proxy for airway collapsibility. In addition, estimates of peak RIT, as predicted by positive airway pressure titration during a laboratory PSG, may predict response to INSPIRE, with patients requiring less than 8 centimeters of water pressure experiencing significantly higher success rates than those with higher pressures. The 5-year prevalence of major depressive disorder in this patient population with OSA is 3 to 7 times higher than in general. And we already touched on insomnia and anxiety. Implantation is a 90-minute procedure. It really has a fast recovery. Patients usually only need over-the-counter for some pain management. They can return to non-strenuous activities in the next few days. They will have their post-op check 1 week after with ENT, and then light activities for the next 2 weeks. Previously, implantation required 3 incisions, and now sensing lead is smaller, so there are only 2 incisions. Intermittent pulse generator, or IPG, is typically placed below the inferior border of the clavicle on the right chest, above the fascia of the pectoralis major. The pressure sensor placed between the external and internal intercostal muscles along the lateral chest wall allows for analysis of chest wall motion, which in turn allows for processor to signal the end of expiration and start of inspiration, the pivotal time at which airway obstruction can be reversed. IPG connects via stimulation lead to the hypoglossal nerve, deep to the submandibular gland, myohyoid muscle, and the tendon of the digastric. Neck and chest x-rays are often performed to document position of components for future reference. Pacemakers or other devices can be present without issues, and this is just an older version with a longer sensing lead. This is my favorite part of the journey. Patients are excited and ready to go. 4 to 6 weeks after implantation, patient is scheduled for an activation visit. After taking history, we need to make sure that there are no issues with the implant, such as difficulty talking, swallowing, pain in the tongue, pain around the device. Isolated hypoglossal nerve palsy or neuropraxia is a rare postoperative complication causing ipsilateral tongue deviation, dysarthria, or dysphagia. If any issues are present, we will delay activation accordingly. We then proceed with our physical exam, check for both incisions, make sure that the tongue is moving nicely up and down, side to side. If all looks good, we proceed with the activation. Initial activation establishes sensational threshold, aka voltage at which the patient feels stimulation, and functional threshold, voltage at which the tongue moves forward. Goal is to find settings that are comfortable and will provide restful sleep. It is important to go through sleep habits to set initial delay of action. When the device is turned on, patients should feel an initial pulse of the tongue motion to let them know that the device is working. The device will then delay any further stimulation for reported sleep latency time at least, allowing patients to fall asleep without feeling any sensations. There is also a pause feature that allows the patient for the device to temporarily be shut off. This can be used if patient needs to get up in the middle of the night. The total device duration is set for the expected time of sleep. Stiffened protrusion is the expected tongue motion. Typically, the tongue moves straight or to the side opposite of the implant. Occasionally, the tongue may move to the same side of the implant, and if there is protrusion, then this is acceptable. After finding the functional threshold, we will set the patient controls, which include starting voltage with a range along with timing settings. We also need to check our sensing lead waveform. So on this patient, it does take a couple of breaths. So usually Inspire will say that we should run this for 3 minutes. We usually run it a little bit less. And what we are looking here is for the Inspire to really catch that beginning of inspiration and then stopping at the end of expiration. We continue by reviewing the Inspire app and going over how to use the remote. This is often done by an Inspire tech present at the visit. We will then discuss the usage of therapy all night, every night, and step up every 5 to 7 nights, extending more if there is any discomfort. Phone follow-up by nursing in 2 to 3 weeks is an important tool in our office. The ultimate goal is to continue slowly and advance the steps until maximally tolerated level and recognizing issues early. Follow-up with the provider is scheduled in the clinic in 2 months. Even though we cannot change settings remotely, we are able to access usage data and patient subjective inputs. Definition of success is AHI less than 50% from the start point and below 20 to 15 per hour, ESS less than 10, and usage of more than 4 hours per night. Majority of patients will do well and follow the so-called green pathway. The numbers listed here are suggested by the manufacturer. Not all will be smooth sailing, and we need to dig deep why. What is the issue? Is the stimulation too strong? Inability to fall asleep? Inspire waking the patient up? Is the patient still snoring? Do they feel sleepy during daytime? Going through sleep hygiene and habits, identifying any new stressors or new mood disorders, going back to patient expectations. And it is often helpful to detangle, is it an adherence issue or efficacy issue? Adherence issues can sometimes be resolved with just education, setting reminders to turn the Inspire on. Efficacy issue is a little bit more trickier. Repeating the exam is essential, and seeing if only by slightly changing amplitude, we can keep tongue movement without discomfort, and then stepping up more slowly. Amplitude is the primary strength adjustment. Inspire can go anywhere from 0 to 5 volts in 0.1 increments. If discomfort is still present, we can try changing the comfort settings that include pulse width and rate. Pulse width ranges from 60 to 210 microseconds and can be changed in 30 microsecond intervals. So in this patient, we see a higher amplitude with a shorter pulse width, but the energy that we are delivering to the nerve is exactly the same as with this patient who has a longer pulse width, but smaller amplitude. Rate change is how the patient's sensation of stimulation smoothness feels. And we usually start with 33 hertz, ranges anywhere from 20 to 40. 33 hertz or higher is recommended to prevent suboptimal nerve capture. Inspire does help us by giving us some settings that we can follow. If efficacy defined as sleepy, poor tongue movement, especially retraction or rightward deviation, are still issues, changing electrode configuration can sometimes help. The whole system can be unipolar or bipolar. Cuff itself has 3 electrodes that can change polarity, and changing the electrode configuration of the stimulation cuff can capture different nerve fibers and significantly improve comfort and/or tongue motion. Note that when changing the polarity, voltage should be reduced by 50% when testing the new setting. If you need minus, 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 which is the strongest setting, advance slowly. We usually recommend advancing every 2 weeks and not the typical 5 to 7 days or less. Follow up in 6 weeks back in the office is recommended. At every follow-up visit, we're going to verify tongue motion with stimulation. We're going to verify our sense lead waveform, our adherence, and subjective benefit. This is where tools such as ESS, FOSQ, ISI come in handy to monitor longitudinal progress. Confirmed start delay and pause time still meet our patient needs. Avoid overstimulation. If despite our changes, we still have issues, it is time to talk to our friendly ENTs. Maybe consider repeating a DICE to find best possible settings. Awake or drug-induced sleep endoscopy is a tool to improve AHI specifically, and in some cases can assist with improving adherence. In the office, we can only see the general tongue movement, but we're uncertain what is happening at the base of the tongue. Slide here shows what we would love to see with stimulation. Of note, endoscopy is only recommended after office-based adjustments. Once patient has titrated his hypoglossal nerve stimulator and is feeling refreshed, ideally no snoring, it is time for a fine-tuned PSG. This slide is showing a 5-minute snippet of one of our patients showing severe obstructive sleep apnea with DSATs and microarousals. And just to orient you to our montage, here we can see the eyes, the EEG electrodes, the chin, then we can see our p-tau thermistor, our bands, and our saturation. And we see that this patient, again, a lot of events with microarousals and DSATs. Once therapy is activated at a titrated amplitude seen by the artifact in the chin lead, there is immediate stabilization of the airway, normalization of blood oxygen saturation, and note that the patient remains in stage 2 sleep and there are no further arousals. Going to a 10-minute snippet, the goal of the titration is airway stabilization without arousing the patient. It is important to follow titration protocol to ensure balance of airway stabilization and avoiding over-titration, which could lead to arousals and worsening of sleep-disordered breathing. Now let me show you what happens when Inspire works. So this video is representing a patient from the STAR trial during sleep endoscopy with the device turned off. The tongue base is completely collapsed and the soft palate as well, and this is representative of an obstructive sleep apnea. Here, the device is turned on at the titrated amplitude in the same patient during the same exam. The stimulation moves the tongue base forward on every breath, and now the tongue base and the palate opens with stimulation, and this is termed palatal coupling. In this case, Inspire addressed multi-level collapse. When therapeutic settings are found for the patient and we have success, a recommendation is to decrease their control limits from 1 volt range to 0.5 volt range with yearly follow-ups. This will prevent overstimulation while still giving the patient some control and flexibility. IPG batteries last 10 to 11 years, and we only replace the IPG at this time. In regards to adverse events, 8 to 18% will have some stimulation-related discomfort at 1 to 2 years. 4% will have some insomnia and arousals. 3% will have tongue abrasion and irritation from going over the teeth. 1 to 2% will have some infection. More serious complications, such as device exposure, pneumothorax, wound infection requiring explantation, hematoma requiring evacuation, and device malfunction after cardiac conversion have all been described but are rare in frequency. Twiddler syndrome occurs uncommonly in patients with pacemaker and deep brain stimulators. Deliberate or accidental device rotation precipitates lead winding and retraction, causing failure to sense or capture or stimulation of the surrounding tissue, and our patients may complain of some neck tightness, erratic activation, and stimulation of jaw muscles. On this patient, we see they usually will just twist the device in their chest, and we can see how the wires are completely winded. There are still a lot of unknowns about hypoglossal nerve stimulator. What are the intermediate outcomes on inflammation and vascular function? Will hypoglossal nerve stimulator really be significant in hard outcomes such as risk of cardiovascular disease and mortality? Long-term outcomes are limited by dropout. Comorbidity treatment is very important, but there are still many questions there. Combination therapy, especially with ansa cervicalis, maybe a mandibular device, is definitely on the horizons. Recognizing the non-responders is very important as well. I will finish with a study looking at 222 patients, 126 patients that were matched 1-to-1 in regards to age, BMI, and AHI. After matching, no statistical differences were found between PAP and INSPIRE group. A clinically important symptom improvement was seen at 12 months in both cohorts, though there was a greater difference in ESS improvement in patients treated with INSPIRE. In both groups, mean post-treatment AHI was significantly reduced. Adherence after 12 months among patients treated with hypoglossal nerve stimulator was higher than those receiving PAP therapy, but not with statistical significance. I could not find any studies comparing mandibular device to the upper airway stimulator. The gist of it all. The way we quantify sleep apnea is definitely imperfect. PAP still remains the first-line therapy if tolerated and used. INSPIRE represents a novel neurotherapeutic device for PAP-intolerant patients with moderate to severe obstructive sleep apnea. Patient selection, clear expectation, close follow-ups are pillars of success. Thank you very much.
Thank you, Dr. Buntak. That was an excellent, excellent comprehensive review of the current literature on hypoglossal nerve stimulation. Also a fantastic review of the clinical pathway, and also you gave a lot of practical pearls and insights on INSPIRE management. So if there's any questions from the audience, feel free to unmute yourselves and you can ask the question, or if you would like to type in the chat. I can moderate as well. Okay, Dr. Tobias says, wonderful talk, Dr. Buntak, thank you. And while we wait for some questions, I do have one question. At the VA, we have patients who, are, as you've worked with me in INSPIRE Clinic, we have patients who have stayed in that yellow pathway, unable to kind of get to that stimulation amplitude to offer any sort of meaningful improvement in their symptoms or AHI. And if these are patients that have come back multiple times to clinic, we've made numerous adjustments to the comfort settings, and still we're not getting, it seems like we're not getting anywhere with some of the patients. So I wanted to ask you, what do you think are some of the characteristics of this VA patient population, or just any other factors that may be playing a role in this, and what can we done like moving forward? Yeah.
So definitely the VA population presents a different challenge. In a sense, they have more mental health issues, PTSD, so they're more likely not to wear PAP and be an INSPIRE candidate. But because of this PTSD, insomnia, nightmares, very low arousal threshold, they present a very specific challenge. I feel a lot of times it's, again, from the beginning, setting the expectations, making sure that insomnia is really addressed, is sort of the pillars of it all. And it's very hard. And I feel also our vets like to have control. So also giving them sort of this empowerment, what are your expectations? What do you want to do? If you are not able to activate your Inspire tonight, why was, like last night, why was that? Was it the more discomfort? And honestly, really not being shy and going down on the amplitude. It doesn't matter. Like knowing, okay, we can try, some positional therapy, something like that, and going down to where they're comfortable and slowly titrating up. But I feel insomnia, CBTI is so important.
Yeah, thank you. Thank you for that. Yeah, so it sounds like really assessing those comorbidities, treating their underlying insomnia, which actually leads me to the next question. To what extent does insomnia become a factor in determining someone who may not be a candidate? Like how do you go about assessing insomnia in your patients who are interested in Inspire?
So it's very hard to entangle, is this like primary insomnia or is this comorbid OSA and insomnia? We know that in comorbid OSA and insomnia, unless you address OSA, insomnia doesn't go away. So that's sort of one part of the population. The other part of the population is really working CBTI, digging deep. Do we have good and healthy sleep hygiene and sleep routine? And knowing that it's totally okay, that this is, again, a very slow process. You might be able to wear your Inspire only for a little bit. And again, titrating really slowly and setting the expectations early on. I just pulled up this slide because this was sort of a smaller study of only, I believe, 24 patients, and they were considered high users if they were using their Inspire more than 4 hours, and low users if they were using it less. And insomnia and anxiety were predictors of low users. So definitely something we need to address early on. And these are the challenges that we need to predict and honestly start talking about this on our consultation day.
Thank you for that. There's another question in the chat. The wonderful talk. There are several patients in clinical practice who do not have improvement in AHI, yet reports improvement of the upper score and quality of life after Inspire. How often do you see placebo response in your patients?
So that's very interesting because I do see, so on our so there's two types of studies we can do. One is a fine-tuned study. Your patient says they really feel great. You do a sleep study in lab and you see that really, you turn on the Inspire, the arousals disappear, the airway is open. That's the fine-tuned study. Then we do have our advanced sleep study where you actually do play with a little bit more levels of Inspire. And in that sleep study is where you would kind of try to figure out what amplitude the patient actually needs to resolve the sleep disorder breathing. So I feel that's where you sort of are going to recognize it. And then again, a conversation with the patient. Hey, I'm super happy you feel great. However, I am seeing that you still have some residual sleep disorder breathing, which is putting you at risk for hypertension, adverse cardiovascular events. So we do need to address that, but again, going slowly on the titration.
Thank you for that. Next question I have here from Tyson L. Have you seen any patients use PAP and hypoglossal nerve stimulation together?
Yes.
Or any other combinations with hypoglossal nerve stimulation and other modalities?
Especially patients that have really high ESS, and if they say, drowsy driving, we will, because again, you are qualified to use Inspire if you use your CPAP 4 hours or less. So even when they're implanted and we're activating their Inspire, initially and I don't know if Chris is here or not. He's our Inspire Tech, wonderful guy. He will often, in conjunction with us, say to the patients, please use your PAP as much as you can. Because again, Inspire is a slow process. PAP is a quick fix. You put it on, the pressure applied opens your airway. So absolutely, yes, we will always encourage patients, wearing PAP as much as they can until we reach that level of Inspire. Because the problem is the functional threshold, yes, it moves the tongue forward, but sometimes we actually have to go a lot of steps up, and you cannot go fast up because the nerve will get irritated. They will get a lot of discomfort and awakenings during night. So yes, absolutely. And combination therapy in general, I'm very excited again, Dr. Kent work from Vanderbilt ansa cervicalis stimulation, how that might play a role with the hypoglossal nerve stimulator. I'm trying to see, the mandibular device, if that would be, so there's actually, let me see, I think I have it here. So effective position therapy, right, which is often overlooked, especially in one-night sleep studies, is definitely something on the horizon. This study actually didn't show any difference and was never actually finished. But again, thinking of other things, how can we improve AHI in general while the Inspire is kicking in?
And Vesna, have you by any chance worked with Dr. Zinchuk on patients who may be on a combination of, say, like oxygen therapy, and those who may have high loop gain, and then combining that with hypoglossal nerve stimulation? Because I think you mentioned earlier, some of those OSA traits like low loop gain is a predictor of success. So therefore, maybe someone with high loop gain can be treated with oxygen therapy or any other,
So I
therapy.
personally didn't have patients. I believe Dr. Zinchuk was sharing his experience with me that he did have patients, just like you said, where adding oxygen actually decreases the loop gain, and you sort of get into this tidal breathing, which is, again, much easier for Inspire to work, right? Because we don't have those big swings where the airway closes and collapses completely. It's sort of open. And we already know part of the problem in OSA is abdominal fat, when we lie down, compresses on our lungs, reduces our functional vital capacity and capacity in general. And if our lungs are not inflated, the airway from below is not pulled down, so it's not open. So this is where, again, that tidal breathing, keeping the lungs inflated, is very important. So absolutely, it definitely carries a role.
Thank you. We have Dr. Morgan Soffler asking, do you ever recommend Saliplan or other sleep aids for anxious patients to help them acclimate to the device if they do have some sleep onset delay?
CBTI is by far the best, but I totally agree with you. It's very reasonable using other medications we have at our disposal if they're safe for the patient. Doxepine is fine. Lunesta is like, a lot of people love Lunesta. But again, explaining to the patient from the beginning, this is a bridge. We will not be using this on a daily basis. And again, we know that CBTI is the most effective, especially on the long run. But I do feel that it is reasonable to give them some relief if they are unable to fall asleep. And actually, one of our patients that we had, lovely lady, she developed initiation insomnia because of the device, because she was literally sort of anxiously waiting for the device to kick in. And how we tried addressing that is actually, again, putting the setting down to where she was comfortable awake with the device on, and telling her, expanding the delay time as much as we can, and telling her it is okay to, turn off your device and again turn it on if you need longer time. Just really trying to say that there's no forcing, there's no pushing.
Thank you. Yeah, Dr. McNally has raised his hand. Please go ahead.
That was a nice presentation.
Thank you.
A question about expectations and perceptions. I'm struck there is a lot of direct-to-consumer advertising for Inspire, and I wonder in particular about how it presents CPAP use in a very negative fashion. I asked the question in part because I remember an early presentation about Inspire that the presenter started with, um, as all of us know, many patients find it difficult to use CPAP. And I wonder how much you think the providers, the physicians' perceptions about CPAP influence what the patient expects. The same can be true, I'm sure, of Inspire, and you face that. But I'm still concerned a little bit that there's and I think the term is implicit bias, that some of us have to CPAP as a therapy about what's difficult and what's not. Do you know of anybody, or can I challenge anybody who's looking for a research topic to use some of the tools to look at implicit bias to see if, in fact, that makes a difference in how we present choices of therapy to patients and what they end up choosing?
I mean, excellent question. I can only tell you from my experience, I always start with, I understand the commercials look great, but there are also commercials for CPAP that look great. That's number one. And number two, I start with Inspire is salvage therapy. And I am very clear that PAP in majority of cases will treat your sleep apnea completely. Inspire success is less than 20, which is moderate OSA at times. So they really need to show me that they failed PAP. Like I will push PAP, I will go multiple times over. There are 50 different masks. Acclimatization to CPAP can also be very slow. There's no need to rush. Your OSA did not appear overnight. It was also developed through, some time. So we do have some times to treat it. I definitely will look at if I can find any of the studies, because this is a phenomenal question.
Thank you for that. Is there any other questions? Let's see. We'll get a lot of excellent presentation, incredible lecture. Thank you, Dr. Vesna. Okay. All right. Any final words, Dr. Buntak?
So again, really talking to the patients, mandibular device and CPAP still remain our first choices. Inspire is a very good alternative, but setting expectations early, going slowly, and trying to really figure out who are the patients. I feel we use still the OSA term as sort of this umbrella term. And we know from the work of Dr. Zinchuk, there are so many different endotypes. So there might be patients really that are going to do excellent with Inspire and maybe should even start with Inspire. But we are still not there. Precision medicine, again, it's an amazing time to be a sleep physician because things are going to change so much with the medications, with different therapies. So it is a very, very interesting time to be alive. And because I do have you, Dr. Chu, I will be shameless not to mention some of your work. And I think this is like so important to really figure out, the endotypes of the patient, to figure out who are the patients that would benefit the most from what therapies. And I invite everyone to read this article, which is just such an amazing, bedside application of our knowledge.
Thank you for highlighting that. Yeah, I think if anything, this table here, just as a takeaway that to show us that right now, while we're not quite at prime time, there are some point of care clinical tools that can be used, in day-to-day practice using our sleep studies to have a estimation of someone's a degree of airway collapsibility, whether they have a low or high arousal threshold, low or high loop gain. So this chart here does summarize some of that, and maybe if just by looking into the patient's baseline characteristics on their sleep studies, we can have a better and try to calculate these traits. We can have a better understanding of their potential response to this therapy, and it just helps us make a more informed decision with the patient. Thank you for highlighting that.
And I'll just finish. One of the reasons why we really love Inspire, because it does encompass a lot of OSA physiology. And the other thing, it's, there are so many factors and so many players in the game. I love talking to our ENTs. I love talking to our Inspire techs. It's like this multidisciplinary team with our nursing, and it's just, it's lovely. It's really lovely. It's great to be a part of this.
Well, thank you very much, and thank you for everyone's attendance. Is there any other announcements, Dr. Thapa, before I close this meeting?
No, Dr. Chu.
Okay.
Thank you.
All right. Well, thank you. Thank you, Vesna. Great job.
Thank you. Thank you.
Thank you. Okay. All right. Bye-bye. Bye-bye, everyone.